The primary function of the cardiorespiratory system is to transfer oxygen and nutrients to the cells and in turn remove the carbon dioxide and metabolic waste products from the various cells. Now, along with an intact cardiorespiratory system, it is very imperative that certain other players also play a very important role, namely the RBC's concentration and the hemoglobin concentration and saturation within the RBCs. Now, what happens if these players, if any one of these players gets disturbed? That leads to an inadequate oxygenation of the tissues. That is a term which is clinically defined by the term hypoxia. Hypoxia is defined as inadequate oxygenation of the body. Now, our basic topic of discussion today is hypoxia and cyanosis. We're going to start off with the discussion of the hypoxia. As I just defined hypoxia for you, the definition shows that it has basically two major players in it. The one is determined by the cardiac output or an intact cardiovascular system. The other player is the oxygen content of the body. Now, oxygen content of the body is basically denotes the respiratory system or the integrity of the respiratory system. We know that we inspired the air containing the oxygen. So it is very imperative that the air which we are inspiring has adequate oxygen concentration in it. Afterwards, the oxygen gets diffused from the alveoli to the pulmonary capillaries. For that to happen, we need to have an intact alveolar capillary interface without any fibrosis or any problem in the diffusion of the oxygen. Once the oxygen gets dissolved in the plasma, that is signified by the P small aO2, which is the plasma oxygen concentration or the partial pressure of oxygen in the plasma. After the oxygen gets dissolved in the plasma, it moves towards the RBCs. RBCs take up oxygen, the hemoglobin takes up oxygen, and it gets saturated after integrating 4 molecules of oxygen. So this whole system is very important. Afterwards, the RBCs carry the oxygen in the form of hemoglobin to the cells, and then later on they take off the carbon dioxide and they move it out to the respiratory system. So all the players here play a very important role, and if we have problem in any one of the player, that can lead to inadequate oxygenation of the body, which is clinically termed as hypoxia. We're going to discuss the various types of hypoxia here and what happens, what are the effects of hypoxia to the body. Let's discuss about the normal first. Why is oxygen very much important for the integrity? We all know that for normal functioning of the cells need ATP. ATP is the energy currency of the cell. And ATP is generated by the oxidative phosphorylation. And the last step in the oxidative phosphorylation requires oxygen. So in the absence of oxygen, there won't be enough ATPs generated and the body will have to rely on the anaerobic glycolysis. And then anaerobic glycolysis is insufficient to meet the cells of the body. And over a long period of time, if that state persists, that can lead to cellular degeneration or the apoptosis of the cells, and it can eventually lead to cell death. So in a normal person, when there is adequate oxygenation, there is a protein called the hypoxia inducible factor, which is induced by the gene called HIF gene, that is normally inhibited. How it is inhibited? Let me show you in this slide. The hypoxia inducible factor HIF alpha as it is represented here, it normally combines with the oxygen and this gets hydroxylated. This step is carried out by the PHT enzyme. Now this hydroxylated hypoxia inducible factor or HIF alpha is then tanned for degradation by the ubiquitinase. Ubiquitinates are basically proteins that tag certain cells in the body for destruction. This destruction is primarily carried out by the proteasomes. So this is what happens in a normal concentration, when there is normal or adequate oxygenation of the tissue. This hypoxia inducible factor is basically triggered on whenever we have absence of oxygen, which is clinically defined as hypoxia. In the absence of oxygen, what happens to this response is because the oxygen is not available, the HIF alpha does not get hydroxylated. And when it is not hydroxylated, the VHL complex is unable to ubiquitinate the non-hydroxylated HIF alpha. It is not ubiquitinated or tagged for destruction. So it remains intact, and it can also bind to HIF-1 beta. This combination of HIF alpha and beta eventually leads to the upgradation of the various anti-hypoxia factor proteins. This can move into the cell, translocate to the nucleus, and can induce the activation of transcription of the genes that can increase metabolism, angiogenesis, erythropoiesis, cell migration, invasion, and eventually cell proliferation and inflammation. All these steps, for example, the erythropoiesis or angiogenesis, are meant to upregulate the RBC's concentration or the increase in hemoglobin availability, which can compensate for the hypoxia. This happens in the absence of oxygen, and this is a response to hypoxia by the body. And eventually it can sustain the normal production up till a certain level, and if this oxygenation is delayed for a longer period of time, then it can lead to eventually cell death or apoptosis, because the cells are unable to survive solely on the anaerobic glycolysis. Let's look at the effects of hypoxia on the central nervous system. As we know that central nervous system is very sensitive to decrease in the oxygen concentration, and the neurons in the central nervous system, they are the quickest to respond to hypoxia, and the effects of hypoxia are more marked, and they are marked in a very short period of time in states of acute hypoxia. And if that hypoxia persists for greater than 5 to 10 minutes, it can lead to permanent brain damage as well. That's why whenever there is hemorrhage or an inadequate oxygen delivery or inadequate blood supply to the various parts of the body vasoconstricts the peripheries. You must be familiar with whenever we have a patient with shock, for example with hypovolemic shock, the extremities are cold. This is because the body vasoconstricts the peripheral vessels and directs all the blood to the vital organs, mainly the heart and the central nervous system, to avoid them getting hypoxic or asphyxiated or hypoxic. So in conditions of acute hypoxia, if we have acute cutoff of the blood supply leading to inadequate oxygenation of the central nervous system, the brain responds by impaired judgment, the judgment of the brain, the motor coordination eventually goes. These are the initial symptoms that can develop, and this is similar to someone who is intoxicated with alcohol. The gait or the motor coordination won't be there, the judgment or cognition won't be there, and this eventually can lead to permanent brain damage if it is for over a long period of time. That's why it is very important to reverse hypoxia quickly to restore the integrity of the central nervous system. Similar conditions can develop on the CNS if we suddenly move someone to a high altitude. That a person who moves to a very much high altitude is not acclimatized, and it takes a certain period of time to get acclimatized to the high altitude. So acutely what can happen, the person might feel some headache, blurriness of the vision, or the GI symptoms, some dizziness can develop. The patient might have insomnia initially because his brain cells haven't adapted, because at high altitude what happens is the percentage of oxygen in the inspired air goes down, and that decrease in the inspired oxygen eventually leads to decrease in the plasma oxygen concentration. That can eventually lead to upregulation of the plasma carbon dioxide, which can afterwards lead to hyperventilation. It is a cycle of events. The hyperventilation can eventually lead to alkalosis in the body, and this strain of events gets triggered. And when someone gets acclimatized over a period of time, there is an increased erythropoiesis in the body, which upregulates the RBC's production, and the person can compensate for that. But acutely, the person might feel headache, dizziness, insomnia, certain GI symptoms. There might be certain fatigue or somnolence. The patient can develop something called high altitude pulmonary edema. This happens because the pulmonary system is somewhat different in its response to hypoxia. Generally, whenever there is hypoxia anywhere in the body, there is vasodilation and there is increased blood supply to compensate for that hypoxia. But in the pulmonary system, the area or the segment of the lungs which is hypoxic, the lungs respond by hypoxic vasoconstriction. There is generalized vasoconstriction to that specific area where there is either inadequate oxygenation or inadequate diffusion of the oxygen. This is basically to conserve or increase the blood supply to the other well-ventilated areas, and those well-ventilated areas eventually compensate for the loss of that small portion. That is a term which is defined by hypoxic vasoconstriction. So whenever someone moves to a high altitude, there is a generalized hypoxic vasoconstriction, and it can eventually lead downstream to the development of pulmonary edema, which can exacerbate the hypoxia by increasing the hyperventilation. So this leads to another cycle of events, and eventually if this pulmonary edema or hypoxic drive is so much large, or the hypoxia is so much greater, it can have an effect on the brain, and it can lead to a high altitude cerebral edema. In the brain, as we know, the response to the chemoreceptors, the central chemoreceptors, is basically dependent on the interstitial fluid pH and the interstitial fluid carbon dioxide concentration. So whenever there is pulmonary edema and there is an increase to increase the blood supply to the brain, the PCO2 at the level of the brain goes up. So there is generalized cerebral vasodilation, and that cerebral vasodilation can lead to extravasation of the fluid from the cerebral capillaries into the brain interstitium. That can lead to cerebral edema. Clinically, how will we differentiate a patient with cerebral edema? The patient will have a severe headache. There might be papilledema. Increased intracranial pressure can lead to an increased intraocular pressure, and eventually, if it is not corrected, the patient can go into somnolence, coma, and eventually the patient might die. So the effects of the hypoxia on the CNS are very important, especially acutely, and in someone who has very acutely moved on to the high altitude and hasn't yet acclimatized. Now let's discuss about the response of the hypoxia or the effects of the hypoxia on the central vascular system, cardiovascular system. As you know that at the aortic arch and the carotid sinus, we have the peripheral chemoreceptors. The peripheral chemoreceptors respond to hypoxia or the decrease in the PO2 after the level has gone down to the below the 60 millimeters of mercury. What is the response to hypoxia? That because the PaO2 has gone down, there is an increase in the PaCO2 or the dissolved carbon dioxide concentration in the plasma, and the body tends to vent it off by hyperventilation or removing the oxygenation by removing the carbon dioxide by the respiratory system. So what happens in case of acute hypoxia? The chemoreceptor reflex arc is triggered. That leads to venoconstriction and the systemic arterial vasodilation. That compensates for the decrease in the oxygen concentration or the plasma dissolved oxygen. The venoconstriction will move more blood to the cardiac system. The cardiac output will be increased, and there will be an increased flow of blood to the arterial system via vasodilation, so that the cells can have adequate oxygenation and perform their activities. And eventually there will be a transient increase in the myocardial contractility because of hypovolemia, stimulating the baroreceptor reflex and increasing the sympathetic discharge. But if this condition is prolonged, then eventually the lactic acidosis accumulates, and it can lead to decreased myocardial contractility with prolonged hypoxia, because in conditions of prolonged hypoxia, the heart cannot rely on the anaerobic glycolysis, and accumulation of lactic acid eventually leads to depression of the myocardium or the myocardial contractility. So this is the effect of hypoxia on the cardiovascular system. Now let's go through a few causes of the hypoxia. The hypoxia can either be a respiratory type, which is the primarily reason, or extrapulmonary hypoxia. We are going to classify them as pulmonary or extrapulmonary hypoxia generally. The respiratory causes of hypoxia are basically you are able to understand the respiratory causes with the help by first understanding this graph. This is the hemoglobin oxygen dissociation curve. Here on the y-axis you have the % saturation of hemoglobin, and on the x-axis you have the dissolved oxygen concentration in the plasma, which is also called the partial pressure of oxygen in the plasma. Now, as you see that with the increasing saturation of hemoglobin, the plasma oxygen concentration, with the increase in the plasma oxygen concentration, the saturation of oxygen goes up. This point here, P50, denotes the plasma oxygen concentration at which 50% of the hemoglobin is saturated by oxygen, or 2 molecules of hemoglobin have attached to the hemoglobin. So any condition that moves the hemoglobin oxygen dissociation curve to the right, it can lead to increased unloading of oxygen. What can be the conditions that lead to the right side movement of the right, or the right shift of the oxygen hemoglobin dissociation curve? An increase in the temperature, an increase in the altitude, increase in the hydrogen ion concentration or acidosis, or increase in the 2,3 BPG, which is biphosphoglycerate. All of these conditions eventually lead to increased unloading of oxygen. These are basically the conditions in which there is hypoxia, for example, in acidosis or with high altitude, or with increase in the 2,3 BPG concentration, or for example, increase in the carbon monoxide concentration. Now, the opposite happens in the leftward shift. In the leftward shift, we have an increased affinity of hemoglobin for oxygen. So, the opposite of the right side, for example, in conditions in alkalosis when there is decreased hydrogen concentration, decreased temperature, or decreased 2,3 BPG, or in certain hemoglobin variation like the fetal hemoglobin, which has an increased affinity for oxygen as compared to an adult hemoglobin because of the two gamma chains, they lead to less oxygen delivery and more attachment of the oxygen. This is also defined here that at lower level of the plasma oxygen concentration, the P50 is reached. Here you can see that in a normal person, somewhere around 25 millimeters of mercury, the P50 or the plasma or the 50% of hemoglobin is saturated. But with an increase in the affinity of the oxygen, you can see here that at levels around 15 or 20 millimeters of mercury, the 50% of oxygen, the 50% of hemoglobin is saturated. And conversely, whenever there is a decreased affinity for oxygen or an increased unloading of oxygen, the P50 goes down. For example, here the 50% of saturation occurs somewhere around the 50 millimeters of mercury. So P50 is a good indicator. Whenever we have an increased value of P50, we can see that there is something which leads to unloading of oxygen or decrease affinity of the oxygen, and the converse happens here when the oxygen hemoglobin dissociation curve is shifted to the left. Here in this diagram, we are showing what happens at the level of the hemoglobin. You know that hemoglobin is composed of the heme molecules along with the 4 globin chains. The 2 alpha and the 2 beta chains are present in the adult hemoglobin. When oxygen is attached to the heme molecules here in the 4 chains, this is a normal condition when oxyhemoglobin, which we term as oxyhemoglobin, the hemoglobin is oxygenated or saturated with the oxygen. Deoxyhemoglobin is the hemoglobin which has lost its oxygen. As you can see here that there is no green part or the oxygen here attached. You can see the 2,3 BPG or the 2,3 biphosphoglycerate here. It basically phosphorylates the 2 beta chains here by forming the salt bridges, and this phosphorylation leads to a decreased affinity of the hemoglobin for the oxygen, and it can eventually, when there is decreased affinity, the hemoglobin is easy to unload to the cell or the tissues. So with that, in the presence of 2,3 BPG or increased 2,3 BPG concentration, this ionic bond or the bridging between the beta chains leads to the formation of deoxyhemoglobin or the removal of the oxygen from the hemoglobin. So this is an important clinical pearl to understand what happens, what is the mechanism of 2,3 BPG leading to the formation of deoxyhemoglobin. Let's look at a few causes of the respiratory hypoxia. At the level of the pulmonary system, what can go wrong? The number one thing which can go wrong, or the most common cause, is the ventilation perfusion mismatch. Either there is inadequate ventilation of the pulmonary system, or either there is inadequate perfusion. Inadequate perfusion means that the areas which are normally ventilated, they have a reduced blood supply, or inadequate ventilation means that the blood supply is normal but the oxygen exchange is not taking place at those areas. So these are clinical which are in common terms referred to as the dead space, in which there is no alveolar capillary interface available for the oxygenation. So any ventilation perfusion mismatch can lead to respiratory hypoxia. If there is hypoventilation, this is generally because of something going on outside of the pulmonary system basically. It can be because of a CNS cause, for example, certain narcotics or sedatives, if there is loss of the diaphragmatic muscle contraction because of certain neurological diseases like Guillain-Barré syndrome or multiple sclerosis or myasthenia gravis. So anything that is basically hampering the oxygenation or the ventilation normal ratio of the ventilation, it can lead to hypoventilation. And that can lead to accumulation of the carbon dioxide in the body and reduced plasma oxygen concentration. Or if there is an intrapulmonary right to left shunt, whenever there is a shunt is basically a bypass of the blood. For example, if there is an arteriovenous malformation in the pulmonary system which bypasses the pulmonary capillaries, so there is no blood available in the pulmonary capillaries for the gas exchange. Similarly, if someone has atelectasis of a large area of the lungs, here again the pulmonary gas exchange cannot take place, and that also leads to the formation of a right to left shunt. This shunting can also occur in the extrapulmonary areas. For example, the cyanotic heart diseases or the congenital heart diseases, they are right to left intracardiac shunting. But those are the extrapulmonary causes. At the level of the lungs, the major causes are the ventilation perfusion mismatch, either due to a diffusion impairment because of thickness of the pulmonary alveolar capillary interface, for example, in certain fibrotic diseases, or because of the COPD or obstructive diseases, for example, emphysema, or in certain restrictive diseases, for example, asbestosis or sarcoidosis. So there is an increase in the collagen in the interstitium in the restrictive or the fibrotic diseases that basically hampers the adequate oxygenation. The hypoventilation is basically anything that downregulates the drive of the normal ventilation system, be it the narcotics or the sedatives or the problem with the chest, for example, a flail chest or kyphoscoliosis, or someone with the diaphragmatic paralysis or phrenic nerve damage. And shunting is basically any area of the lung which has no blood supply to it. Or for example, if someone has atelectasis of the large area of the lungs, that area is unable to contribute to the gaseous exchange. Let's look at the extrapulmonary or causes of hypoxia. These are generally classified in the other causes. There can be a hypoxia secondary to the high altitude, as we talked about the effects of the CNS. When we go at the high altitudes, there is decreased oxygen concentration in the inspired air, and eventually it leads to hyperventilation, the development of alkalosis, and it leads to right shifting of the oxygen hemoglobin dissociation curve to compensate for that hypoxia. Similarly, hypoxia can develop secondary to the right to left extrapulmonary shunting. For example, in certain cyanotic congenital heart diseases like the absence of the vascular septum, ventricular septum, the VST condition can develop, or total anomalous pulmonary venous return, TAPV. These are generally evident right from the birth, and the cyanosis can develop in infancy, and they are easy to diagnose in infancy. Similarly, if we do not have enough hemoglobin in our system, the patient is anemic, there is a decrease either because of deficiency of iron or because of any other cause of anemia. If the hemoglobin is not available to carry the oxygen, then how can we adequately oxygenate our system? So any cause of anemia can also lead to hypoxia. Similarly, if in place of oxygen, the hemoglobin gets attached to the carbon monoxide. What carbon monoxide does is it decreases the affinity of the hemoglobin for the attachment of other coming oxygen molecules. So when carbon dioxide gets attached to the hemoglobin, it is termed as carboxyhemoglobin, and it leads to unloading of the already attached oxygen molecules, and it prevents the attachment of the further coming oxygen molecules. So eventually we have a decreased saturation of oxygen with hemoglobin. Carbon dioxide intoxication, as you know, can develop if someone gets in a confined space with a fire or exhaust of the car. For example, in a small garage, if someone has a running car, that person can develop carbon dioxide intoxication. Clinically, it is defined by the cherry red discoloration of the body, of the lips. The person will have headache, The similar effects on the CNS might develop. The person might have dizziness in coordination at the motor level, and it is treatable by giving someone 100% oxygen or placing them in a hyperbaric chamber that can get rid of the carbon monoxide, and eventually the oxygen can come. Similarly, if there is a circulatory hypoxia, there is just not enough blood to carry the oxygen. For example, if someone who has had profuse hemorrhage or profuse diarrhea or dehydration, then there is just not enough blood in the body to carry the oxygen to the cells. So in this case, we need to replenish the person with the blood or the normal saline to maintain the normal blood pressure, so that the cells can replenish themselves by the oxygen which is carried out into the blood or the plasma. And the hypoxia can also occur at a specific organ level. It is generally when it is confined to certain organ level. For example, if generally the patient is fine, but his arm gets hypoxic because of occlusion of the blood supply to the radial or the brachial artery or the axillary artery, then that is limited to one part of the body. Or for example, at the level of the organs, if we have a acute renal failure because of sudden cessation of the blood supply via renal artery. So hypoxia can be generalized when we have a generalized problem at the level of the pulmonary system or the circulatory or the cardiac system. It can be an organ hypoxia related to a certain specific organ. And then various organs have counter-regulatory mechanisms to compensate for the hypoxia for some extent. But if it is the hypoxia is prolonged and there is not restoration of enough blood, eventually it can lead to organ damage permanently. And in certain conditions, when we have an increased oxygen requirement, for example, if someone is exercising or if someone has, for example, in a pregnant lady, there is an increased oxygen requirement because of the development of the fetus. So in these conditions, these people are very prone to hypoxia, and it is very important that all the players of the cardiorespiratory system are intact. They have adequate oxygenation, they have adequate hemoglobin, the respiratory system is intact, there is no problem with the cardiac contractility, the volume is fine, for these patients or for these persons to have an adequate oxygenation. And any impairment in any part of the system can lead to a development of hypoxia very quickly in these patient population. So these were some major causes of hypoxia at the level of the lungs or the pulmonary system or the extrapulmonary causes. Now let's talk about cyanosis. Cyanosis is defined as the bluish discoloration of the skin. Majorly, it can be a peripheral cyanosis or a central cyanosis. How does the bluish discoloration develop? This is primarily whenever we have an inadequate supply of oxygen to any part of the body. That part of the body eventually gets blue and goes to a change of the color. The blue color represents the deoxygenated hemoglobin or the inadequate supply of oxygen. It can either be a central cyanosis or a peripheral cyanosis. Central cyanosis is whenever there is a bluish discoloration at the level of the, you can say, the mucosa of the oral cavity can show the bluish discoloration, or any central or generalized, there is generalized cyanosis of the skin. Peripheral cyanosis is when the cyanosis is limited to one part of the periphery. For example, it only develops in the digits and does not develop at the level of the oral cavity or the mucosa or the generalized skin. There are different causes for the central cyanosis and different causes for peripheral cyanosis. Central cyanosis generally develops whenever we have a central problem. There is a generalized decrease in the arterial oxygen saturation. How can there be a decreased arterial oxygen saturation problem? It can start right from the level of the lungs. Either there is a decreased atmospheric pressure or decreased oxygen concentration in the inspired air. For example, someone who is in a high altitude, in that patient, cyanosis can develop centrally because there is just not enough oxygen in the atmospheric air and at the level of the alveoli to diffuse through and meet the supply of the body. If there is an impaired pulmonary function, the oxygenation is fine in the inspired air, the PaO2 is fine, which is the percentage of oxygen in the alveolar level, but there is either a diffusion impairment or a alveolar hypoventilation, or there is inhomogeneity in the pulmonary ventilation and perfusion. All the causes which we discussed of the pulmonary causes of hypoxia. either the alveolar hypoventilation is there, or ventilation perfusion mismatch is there, or either there is central diffusion impairment, or there is a development of some shunt. These can also, these impaired pulmonary function lead to inability of the oxygen to diffuse from the alveoli to the pulmonary capillaries too. So there will be an AA gradient, which is the difference in the oxygenation between the alveolar plasma oxygen concentration denoted by the big A or the capital A, or from the oxygen concentration in the plasma, which is denoted by the small a or the small pa. If there is anatomic shunts, either intrapulmonary or at the level of the cardiac, for example, certain types of congenital heart diseases like the VSD or the ventricular septal defect, we have the right to left shunt, and that's the cyanotic heart disease. Similarly, if there are pulmonary arteriovenous fistulas and the blood just bypasses the pulmonary capillaries, so there is not enough blood at the level of the pulmonary capillaries to participate in the gaseous exchange, or multiple small intrapulmonary shunts can lead to the development of cyanosis eventually over time. Or if there is any problem with the hemoglobin, either it has low affinity for the oxygen, for example in carbon monoxide poisoning, or there are certain hemoglobin abnormalities in which there are structural problems with either the heme part or the globin part. For example, methemoglobinemia, either hereditary or acquired. It is where methemoglobinemia is a condition in which the normal iron is hemoglobin is ferrous iron or Fe positive 2. But if it is reduced to Fe plus 3, that has reduced affinity for oxygen and it is unable to carry out the normal activities. That hemoglobin, which the ferric ion or the Fe plus 3 is called methemoglobin. It can either occur in a hereditary, it can be a hereditary problem in certain patients, or it can be an acquired cause because of certain drugs like the nitrates or the benzos drugs. When we give the patient nitrates or the benzos drugs, they can develop methemoglobinemia. Or if the hemoglobin chain is attached by a sulfated molecule called the sulfhemoglobinemia, it is also an acquired condition. It also leads to decreased affinity of the hemoglobin for oxygen. Or there is carboxyhemoglobin, when there is carbon monoxide poisoning. Similarly, cyanide poisoning can also cause these problems. Or if there are just certain congenital diseases like thalassemia, in which there is just not enough globin chains to carry out the normal process of oxygenation, these patients can also develop central cyanosis. Peripheral cyanosis generally is because of hypovolemia. There is not adequate blood supply to certain parts or the digits. It can also be because of vasoconstriction. So any condition, for example, left ventricular failure or myocardial infarction with a reduced cardiac output, or if whenever we have a reduced cardiac output, the body compensates by reducing the blood supply to the peripheries via vasoconstriction, so that the blood can be pulled up and moved to various vital organs like the cardiac system or the central nervous system. It is imperative to protect the brain and the heart for the overall integrity of the person, rather than and the body compromises on the blood supply to the peripheries, the digits and the toes. So any condition with a reduced cardiac output or exposure to the cold exposure in certain population can lead to vasoconstriction of the fingers. Eventually, initially they become pink, and then they can eventually become blue or cyanosed. This is also termed as Raynaud's phenomena in certain people if it is extreme, and then we have to give them certain calcium channel blockers to make their fingers feel better, because these can be very painful if this is because of a Raynaud's disease or a Raynaud's phenomenon. Redistribution of blood flow from the extremities, especially in conditions where the overall integrity of the cardiovascular system is compromised. Or if there is an arterial obstruction, just anything that obstructs the blood flow through the arterial system, or anything that obstructs the blood flow moving out of the venous. So any obstruction at the level of the arteries or the veins can eventually lead to a development of peripheral cyanosis. So the peripheral cyanosis generally is a localized condition, and central cyanosis develops in people who have a generalized problem. Let me give you a couple of mnemonics to differentially diagnose the peripheral and the central cyanosis. You can remember the causes of the peripheral cyanosis by the mnemonic COLD. C stands for the cold, generally, which is because of vasoconstriction in cold, leading to decrease in the blood supply. O stands for the obstruction, be it arterial obstruction or a venous obstruction. L can signify the LVF or the left ventricular failure and the shock, or any condition that reduces the cardiac contractility. And D also signifies the decreased cardiac output. So cold gives you a good idea that it can either be a problem with the temperature, cold, or an obstructive problem, or a problem at the level of the heart. Central cyanosis can be remembered by the mnemonic PALMS. P stands for the polycythemia. Polycythemia generally is a response to the central cyanosis, but here for the completion of the mnemonic, it is important. It gives us a good mnemonic PALMS to remember the overall causes of central cyanosis. A stands for altitude, primarily the high altitude where there is decreased atmospheric pressure and decreased oxygen concentration in the inspired air. L stands for any lung disease, for example, COPD or any ventilation perfusion mismatch, atelectasis, pneumonia, consolidation, any tumor that leads to impaired diffusion. And M stands for either the methemoglobin or self-hemoglobin, or either a problem in the hemoglobin chain, be it an acquired or a congenital disease. And S can signify for the level of for the purpose of completion, it can signify a shunt, be it an intrapulmonary shunt, for example, in someone with atelectasis, or be an intracardiac shunt, for example, someone with congenital heart disease. So these mnemonics are good to remember to rule out the various types of abnormalities causing the cyanosis. How do we diagnose someone with cyanosis? What are the various investigations which we have? The major ones which we have are the chest X-ray, or the ABGs, arterial blood gases, which can be classified as a hypoxia test, or the sepsis screen if we are suspecting someone with an infection or blood glucose, and EKG or electrocardiogram. Now let's look at step by step what happens if these tests are normal or abnormal. First, let's concentrate on the abnormal side. If you do a chest X-ray in someone with cyanosis and that chest X-ray is abnormal, then that generally shows that there is either a pulmonary problem or a cardiac problem. Let's just forget about the normal for a second. We'll talk about the normal at the end of this slide. Let's just concentrate on the abnormal side of the lecture first. So if the chest X-ray shows some problems, there is a pulmonary or a cardiac problem. If the ABGs show some problem, then we have to look at the abnormal blood gases, whether it is or the acidosis or the alkalosis, either it is because of a cardiac or pulmonary cause or any other part of the body. It can be a renal cause which is leading to an acidosis or an alkalosis. If someone is suspected of having an infection, and the sepsis screen will give us a good idea of a generalized infection, for example, a pneumonia which goes wrong, eventually starts at the level of the pulmonary system and can generalize into a generalized shock or a sepsis problem. So a sepsis screen or a blood glucose gives us a good indication of either it is a problem with generalized infection. The blood glucose concentration gives us a good indication of the glycemic control in someone who is diabetic, either he is hyperglycemic or hypoglycemic. And it can also show the polycythemia can also be, if we do a blood CP of these patients, we can have a good idea of the overall RBC's concentration as well. And the EKG gives us a good indication of what is going on at the level of the heart, if there is decreased cardiac contractility, be it because of any arrhythmia or because of any infarction, so that we can catch it in time with the help of an EKG. If all of these tests are normal, the X-ray, ABG, sepsis, and the EKG screen, then generally we have to look at the other causes. What are the causes of cyanosis in cases where these investigations are normal? Then we have to think at the level of the brain. Either there is certain CNS causes that is causing hypoventilation. Narcotics abuse can cause any level of problem in the CNS or any muscular problem. Either there is a hemoglobin abnormality which we have missed. For example, someone with sickle cell anemia or any other causes of hemoglobin abnormality. These are going to be diagnosed by the hemoglobin electrophoresis. And then we also have to look at the various metabolic causes, whether the concentration of the various ions in the plasma is adequate, whether there is adequate sodium present, adequate potassium present. So we have to investigate on those lines to arrive at a diagnosis of the cause of cyanosis in these patients. How we are going to approach someone with cyanosis step by step. The first point is to ascertain the onset of cyanosis, whether it is present since infancy or it has developed in adulthood. Generally, if someone has cyanosis from his infancy or childhood, it is basically because of a cyanotic or a congenital heart disease. Whether the cyanosis is central or peripheral, because this can be ascertained very quickly by massaging or gently warming the extremities of the person. If someone has a bluish discoloration of the nails and you gently massage the extremity of the person, then that cyanosis goes away. But if someone has central cyanosis as well along with the periphery, the central cyanosis does not go away with this maneuver. So the causes of the central and peripheral cyanosis are generally different. So it is important to ascertain whether we have a central cause or a peripheral cause of cyanosis. Similarly, the measurements of the dissolved oxygen or the PaO2 and the saturation of oxygen, the SaO2, is very important. It gives us a good indication of the integrity of the whole pulmonary system. The PaO2 again gives us a good idea of the integrity of the diffusion or the alveolar capillary interface, and the SaO2 gives us a good indication of the saturation of oxygen, whether the oxygen is adequate, whether the hemoglobin is adequately saturated with oxygen. We can also use certain devices like the spectroscopy to examine the blood. This spectroscopic examination gives us an insight into abnormal hemoglobins. For example, if we have, instead of oxygen, carbon monoxide is sitting in the one of the 4 chains of hemoglobin, then we can rule it out by the help of a spectroscopic examination. It also can give us an insight on the abnormal hemoglobins present. And then when we have finally ascertained the cause of the cyanosis, we treat according to the cause. If there is any abnormality, if there is anemia, we replace the RBCs or the hemoglobin. If there is decreased iron present, just give the patient iron. If there is methemoglobinemia, treat the methemoglobin. If there is carboxyhemoglobinemia or carbon monoxide intoxication, place the patient in a hyperbaric chamber, and that takes care of itself. So this is a generalized approach to a patient with cyanosis. Just ascertain the onset of the cause, differentiate between central and peripheral cyanosis with the help of various investigations, and then stepwise rule out the central and the peripheral causes. At the end of the lecture, let's just talk about clubbing for a second. What is clubbing? This picture here shows classical representation of the clubbing in a patient. This is because of the selective bulbous enlargement in the phalanx of the digits, either at the level of the hands or the toes, because of an increase in the underlying connective tissue or the proliferation of the underlying connective tissue in the nail beds. This can happen in response to hypoxia, and it generally happens in someone who has central cause of hypoxia. If you have someone with clubbing, it is very important to investigate its cardiac profile. For example, look at whether the person has some cardiac abnormalities like a right to left shunt is present, or someone who has infective endocarditis, he can have this clubbing. Or generally at the level of the pulmonary system, they are the major causes of clubbing. So anyone with advanced COPD or a metastatic lung tumor, or a tumor at the level of the lungs, a primarily lung cancer or the mesothelioma, he can present with clubbing. Why this clubbing happens? This is because of the proliferation of the underlying connective tissue is in response to the hypoxia. The hypoxia induces certain changes, and that leads to upregulation of the various platelet growth factors, the VEGF or other growth factors, that can eventually lead to increased concentration of collagen deposition underneath the nail beds. So if we see someone with clubbing, it is very important to think of the respiratory system or the cardiac system, and in certain rare gastrointestinal abnormalities like inflammatory bowel disease or hepatic cirrhosis, clubbing can also develop. In patients with a lung tumor or a hepatic cirrhosis, clubbing can be associated with a condition called hypertrophic osteoarthropathy. This is basically like a condition in which rheumatoid arthritis, in which patients with hepatic cirrhosis or lung carcinoma or mesothelioma have a generalized pain in the various joints of the body, be it at the level of the shoulders or at the level of the knees or the fingers. And this is because of an upregulation of the underlying connective tissue or impaired deposition of the underlying connective tissue. So clubbing is a good clinical indicator of an underlying problem with the respiratory system or the cardiac system primarily, and it needs to be investigated. If you, for example, if you see a smoker with advanced clubbing, you can save his life by timely diagnosing a primary lung tumor before it has metastasized. So clinically, it is a good sign and should always be examined during your generalized systemic examination. With that, we complete our discussion of the hypoxia and cyanosis in this lecture. I will continue with our respiratory system lectures in the internal medicine, and I'll see you in another lecture on the respiratory system. Thank you for watching sqadia.com.